of our Environmental and Health series by the Wisconsin Environmental Health Network, or WEHN. I'm watching the attendee numbers tick up here. So as they're ticking up, I'm going to share my screens for some beginning slides as people are entering the webinar. Again, this is our third webinar of the series. And again, we just want to thank all of our series sponsors that make this happen, and thank you to SSM Health that provides accreditation services for this series. We have quite a few folks that are receiving continuing medical education credit for this series. So just thank you to all of you. I see some people trickling in. We'll just keep on getting started though. So Wisconsin Environmental Health Network, or WEHN, or WEN, is a group focused on bringing the public health voice to many issues, but really focused on environmental health. We provide educational resources like this webinar series. We provide advocacy measures and action alerts to our members, and we provide information that helps establish strong protections for public health and environmental health, especially in the state of Wisconsin. I have our website on here. We also have a Facebook or Twitter if you want to stay up to date or to join us on any upcoming events or news or any of the like. A few things of what to expect from this presentation. As you're getting familiar with, this is Zoom. We are in webinar format, so only panelists are visible. Attendees are not visible. The event is being recorded, and actually it will not be on YouTube. That slide is wrong. It will be recorded though. And to submit a question, please use the Q&A box. It's located on the bottom of your screen. It has two bubbles and it's labeled Q&A. You can submit a question at any time during the presentation, and then we will do questions at the end. So all of the questions that we can get addressed at the end before 8 o'clock, we'll try to do. And then if you are calling in, I think it's *9, or you can email us at wehnmail@gmail.com. And then a few things about perspective. When you're viewing a screen, you have a middle slider on your screen that's vertical. You can move it back and forth to adjust how big the speaker is versus the presentation. So just a tip. And now I'm going to turn it over to Dr. Beth Neary, who is the co-president of the Wisconsin Environmental Health Network and a pediatrician, and she's going to introduce tonight's speaker.
Thank you, Hannah. It's my pleasure to introduce Dr. Frederica Perera. She is the founding director of the Columbia Center for Children's Environmental Health at Columbia University. She's also a professor of environmental health sciences. She is internationally recognized for pioneering the field of molecular epidemiology, utilizing biomarkers to understand links between environmental exposures and disease. She's the author of over 350 publications and has received numerous honors. One of them is the Children's Environmental Health Excellence Award from the US EPA in 2005. And another one is the 20th Annual Heinz Award in Environment for her lifetime achievement in research for the protection of children's health. Welcome, Dr. Perera.
Thank you so much. Now I'll share my screen. And let's see, whoops. This is where I run into problems. I guess I should escape. Sorry. Okay, try again. Share screen. Do that. Share, but I need to put it on. For some reason, it's not wanting to do slideshow. There we are. Now I'll switch display. Okay. Does that look all right?
Yep, looks wonderful. You're good to go.
Okay, a little technical challenge there. All righty. So hello, everyone. Thanks for joining. I'm going to talk tonight about the multiple threats of climate change to children's health and equity, but how we can benefit from how they can benefit from our actions. And I'm going to kind of whiz through a bunch of topics, spend more time on the last part of the talk, but we'll just briefly review the emissions and the sources from fossil fuel combustion, and the dual crises. From fossil fuel, we're getting not only climate change, but also air pollution. And the exquisite vulnerability of the developing fetus, infant, and child, the various health effects and how they can combine, health effects of air pollution and climate change, the disparities in both in exposures and health burden. And I'll take us through some examples from our own research at the Columbia Center for Children's Environmental Health. And then we'll turn to some of the good news, which is the health and economic benefits of climate and clean air policies and what we've learned from that experience. So the next slide shows the fact that we're dealing with both a challenge and opportunity, according to Lancet, both the challenge and the opportunity, the biggest ones of our entire century. And the challenge has recently gotten worse, and we've been told by the International Panel on Climate Change, the UN IPCC, in their latest report last week, that the climate change impacts are basically worse than we had thought. The speed of change is faster than we had predicted, and it's outrunning our ability to adapt. And yet they also said there's an opportunity to make a difference and to act in time. So I like this Chinese character, which means turning point. And I think we are at that turning point. And I think we can do it. It's the character is a composite of the Chinese character for danger or challenge and opportunity. And I think this is very apt for the moment in time that we are facing. Emissions from burning of coal, oil, gas, diesel fuel, natural gas are the root of the problem. And we are very familiar with these sources. This is a residential building in northern Manhattan, right near where I work at the Columbia School of Public Health, Mailman School of Public Health. Now, these sources, fossil fuel combustion, is responsible for 80% of toxic air pollution and about the same percent of carbon dioxide, the main climate altering gas or greenhouse gas. Every year, we are dumping 48 million tons of respirable particles into the air. And the recent tally of global emissions of CO2 have skyrocketed to 35 billion metric tons a year. Oil and natural gas operations emit 82 million metric tons of methane worldwide. And we now understand more about methane, which is the second most important greenhouse gas, and how very important it is in this problem. This graph really demonstrates the steep increase both in carbon dioxide and in air temperature over the years since 1880, particularly steep since in the last 3 decades, basically since 1980. And do you remember 350.org? And then do you remember the 400? I mean, the concentration of CO2 that we weren't supposed to pass, the 350, then it went to 400. We're now at 410 parts per million. We've blown past these milestones. And so indeed, the situation is serious. And I know you all understand that. The IPCC, this International Panel on Climate Change in 2018, announced that we need to hold warming to below 1.5 degrees centigrade by the end of the century. But we have a 12-year window to act, and that attracted a great deal of press. Well, now we have an 8-year window to act. This is 4 years later. And we're still understanding that we haven't at all acted in time and as much as we need to do. The post-Glasgow meeting on climate change, COP26, gave us some new targets and new pronouncements by governments. But even if all those targets are met and on time, the best we can hope for is a 1.8 degrees centigrade increase in temperature by the end of the century. So it's indeed serious. As much as 90% of the global population is exposed to air pollution above WHO guidelines. So that's an enormous problem. The UN Secretary Antonio Guterres, Secretary General, has called these reports by IPCC and the most recent ones Code Red for Humanity. And as I mentioned, the most recent report is saying climate change is outpacing our ability to adapt. Okay, so this is the worsening state. Why are we so concerned about the dual effects, or why am I so concerned about the dual effects and interactive effects of air pollution and climate change, all coming from the same source, from fossil fuel dependence? Let's run through the air toxics themselves. You have quite a list here. Particulate matter in the fine respirable range, PM 2.5. PAH stands for polycyclic aromatic hydrocarbons. We also have the emissions of nitrogen and sulfur dioxides and precursors to ozone. This is ground level ozone. It's a very strong respiratory irritant. Then on the right, we have the impacts of climate change, from higher temperature to precipitation extreme, both rain bombs in certain areas and in others, drought. We've seen a shocking increase in extreme weather events, hurricanes and floods all around the world, including in the US. We've seen more forest fires as the soil has become drier, and more allergens, more pollens released. And there's an interaction between air toxics and climate change. We see that at higher temperatures, the formation of ozone is surface level ozone is accelerated. We see that that forest fires are providing enormous loadings of particulate matter and black carbon, adding on to the ambient concentrations from the combustion of fossil fuels. So, and I could go on. There are many different examples of combined effects and synergy. Similarly, when we look at the health outcomes, now I've listed the various health effects that have been associated with these different exposures. And I want to stress that these are known to be causal or likely to be causally related, I should say, through associative studies, epidemiology. And on the left, we see the air, and the other striking thing is that we see a lot of overlap. We see under the effects associated with air toxics, we see the adverse birth outcomes we see over here with climate change. Also asthma exacerbation on both sides of this slide. We see neurodevelopmental disorders repeated, and mental health disorders particularly, and I'll focus a bit more on that because we now have something like 14% incidence, or prevalence, I should say, of mental health disorders in children and adolescents, and the rates have escalated in recent years, and both climate change and air pollution are contributing. Now they're contributing along with multiple other factors, but they're significantly contributing. And in a survey that was administered around the world, nearly 60% of young people said they felt extremely or very worried about climate change. And 2/3 reported feeling sad, afraid, and anxious. These young people are at greater risk of mental health issues. And that's just from climate change. Now, let's think a moment about the interactions. The same children often experience simultaneous exposure to both, and the combined effect we're seeing may be greater than additive. about 1 in 3 children, estimated 850 million children in the world, live in areas where at least 4 climate and environmental shocks are overlapping. So there's plenty of exposure to both simultaneously and certainly sequentially. So if we give let's take a few examples. So a large study has found that both air pollution and extreme heat are significantly associated with preterm birth. And the combined effect in this large study was actually multiplicative or synergistic. We also can understand that children who are born preterm due to air pollution and heat are likely to be at greater risk later on of climate-related malnutrition and infectious disease. And I could go on about the combined effects, but you can get the message that we need to be thinking of these in a holistic way, as they are all coming from the same fundamental source of burning of fossil fuels, production of fossil fuels. The susceptibility of the fetus and child is at the heart of the matter because of the very complex and rapid development of the brain, respiratory, and other systems. There are great opportunities for disruption by toxic exposures and social stressors. Just as an example, we're supposed to have, I hope we all have 90 billion neurons in the adult brain, and these are mostly formed before we're even born. That's an amazing statistic, I think, testifying to the rapidity of development. And because of the complex programming during this early stage in the fetal window, there's a great opportunity for disruption. Higher exposure to toxics on a body weight basis is also playing a role. Kids or children, the young, are taking in more air, they're taking in more food and water on a body weight basis, and therefore taking in more toxics that are found in those media. And they also have the immature detoxification systems, the enzyme systems that are functioning in adults to detoxify chemicals and pollutants. And their DNA repair systems are likewise immature. So they're more vulnerable for that reason. They also have greater nutritional needs, something like 3 to 4 times the amount of food on a body weight basis is required in the young child compared to the adult. And so they're much more vulnerable to malnutrition due to food insecurity from drought, for example. These factors place them at greater risk of psychosocial stressors. And then we know that many of the health effects we saw in the last slide can persist over the life course and affect functioning and health through the individual's life. There's also much evidence about the seeding of chronic diseases in utero, diseases that manifest and play out later in life. And possibly transgenerational inheritance is a factor here, a concern, I should say, due to epigenetic changes, which have been shown to be heritable across generations. And this slide is really simplified, but it shows you how very complex the development is during the first 9 months and demonstrates how most of the brain's architecture is established during this period, making the brain very sensitive to disruption to cellular molecular damage from exposure. The brain still is developing in childhood and adolescence, so these two are very vulnerable periods. But we can understand why we need to pay special attention to the young and including the developing brain. There's another huge issue here, and it's really dual. Environmental climate injustice. The first factor in this injustice is that children, through their vulnerability, are bearing the brunt of air pollution and climate change. And we have an earlier estimate from the World Health Organization that as much as 88% of the existing global burden of disease due to climate change falls on children under the age of 5, even though they represent 10% of the global population. And also we have the injustice that there is inequity in terms of exposure and risk that there's disproportionate exposure to toxic air pollution and climate change risks in developing countries compared to the more developed countries. And also in the rich countries like ours, communities of color and low income have a disproportionate exposure and risks. So dual climate and injustice, environmental climate injustice. We know that environmental and socioeconomic psychosocial stressors from racism and poverty interact with physical toxicants to magnify adverse health effects. And so the young and those in disadvantaged populations deserve special protection, and we need to act on simultaneously on adaptation and mitigation. So now I want to take you through some of the studies we've been doing in New York City and in other countries at the Columbia Center for Children's Environmental Health. These are international cohort studies. And we've been using the approach that was mentioned in the introduction, molecular epidemiology, back in 1982, my goodness, a long time ago. Bernie Weinstein and I proposed this conceptual framework whereby we would use biologic markers that we could measure in blood or placental tissue or even urine or other biological specimens that could help us understand the links between environmental exposure and clinical disease, and help us learn how to intervene rapidly before a clinical disease was manifest. In other words, raise red flags. And these biomarkers could indicate internal dose or biologically effective dose or even preclinical effects of those exposures. All of these on the pathway to clinical disease, and also markers of susceptibility so we could better understand risk. And we've used this approach in our studies in New York City. I think I'm sharing a screen with the part of our, yeah, I'm going to move that down, sorry. So in our studies, we have measured, We've focused on all three on polycyclic aromatic hydrocarbons and many other chemicals, but this is a common theme. So I'll just mention that they're pervasive in the ambient air. They're found in fine particulate fraction, very versatile. They're both damaging to genes, genotoxic, and they disrupt the endocrine system. And so they're particularly concerning. And we measure those pollutants in a number of ways through area monitoring and personal backpack monitors during pregnancy, measure the metabolites of PAH in urine, and also the adducts formed when PAH are activated metabolically and bind to DNA. And this cartoon shows one of the PAH benzpyrene bound to DNA. It's a stable adduct, and we can measure it down to low levels on the biological specimens. And we've done that in umbilical cord blood and many other specimens. Across the three cohorts in New York City and Krakow, Poland, and China, we see consistency in the associations between prenatal PAH exposure and birth outcomes, cognitive behavioral outcomes, and where we've been able to look at them, asthma and respiratory outcomes. And so these are associations are consistent across different racial ethnic groups and different gradients of exposure and exposure settings. The New York City study enrolled 720 mother-child pairs starting in 1998. And the women are African-American, Dominican, they're residents of Northern Manhattan and South Bronx, most low income on Medicaid. We recruited them during pregnancy and collected maternal urine and blood, and conducted the prenatal personal air monitoring. Cord blood and placental tissue were collected at birth, blood and urine from children, and we followed the children sequentially all the way through adolescence and beyond. And our oldest children are now 23, which is hard to believe. We have two other cohorts in New York City as well, but I won't take you through all of that. But just to briefly review what we found in terms of associations between prenatal exposure to PAH and outcomes. And these are some of the outcomes listed in that early slide on health effects of air pollutants. And I won't go through them all, but they were all significantly associated with exposure after adjusting for potential confounders, other contributors that could explain the effect that we observed had we not taken them into account, and would give us a spurious association if we hadn't taken them into account. So the effects range from the adverse birth outcomes to asthma to cognitive and behavioral problems, even extending to ADHD and a decreased social responsiveness, a trait of autism. We also have seen MRI brain changes linked to those exposures. So that's the bad news. Some good news is that our data have been credited with supporting citywide policies in New York to reduce air pollution. And those regulations included clean air, diesel bus and truck legislation, clean heat program to replace the very polluting residual fuel oil used to heat buildings in the inner city. And in our cohort, taking into account all the monitoring, the personal air monitoring from the time we first enrolled women all the way through to the present, we see a significant decline in their prenatal exposure. So that's good news for the mother, for the baby. And our findings, as we received notice from Michael Bloomberg, the former mayor of the city, he told us, or wrote us, that our findings had been helpful to them, encouraging their administration's work and commitment to reducing air pollution throughout the city. So that's good, because one often never hears that there's been any, that policies have been affected by the data. Here's another case study, this time in Krakow, Poland. It's a city in southern Poland, one of the most polluted cities in the EU due to heavy coal burning. And the major source has been coal burning in stoves for home heating. Until recently, many houses had black plumes coming out of their chimneys. I remember arriving when I first came to Krakow early around 2000, and it was in the winter, and it was snowing on me. I didn't see it as snow because it was gray, and yet it melted on my skin. So I figured that, oh, that is snow, but with soot attached. So it was pretty polluted, and very polluted, as I say, most polluted in the EU at that time. We enrolled over 500 mother-child pairs. The study's ongoing, follow-up's ongoing, and I want to mention my beloved collaborator, the late Wiesław Jędrzejewski, professor at Jagiellonian University of Krakow, with whom we mounted the study, and his team has kept the study going. And we saw similar effects to what we saw in New York City, health in terms of the birth outcomes, the respiratory health, the cognitive and behavioral problems, and an interaction, which I'm not sure I mentioned in the New York City work, that we saw a significant interaction between exposure to PAH and material hardship due to poverty on IQ of children. And we see the same interaction in this cohort in Poland, material hardship due to poverty, and not only on IQ, but also on behavioral problems. So these are consistent associations again, and the reduction in IQ, or the equivalent of IQ intelligence scores in Krakow, was similar to that in New York City, about 4 points, which you see with low-level lead. So it was a significant decrement. Now, more good news in that our data have been helpful, supported advocacy by Smog Alert. That's a campaign that was founded in Krakow to tell the authorities, the government, that they needed to take action. Their children were getting sick, and the emissions have come down over time between 2010, 2019, shown here. And the red line is the average for the heating season only, where you would expect to see more of a bang, because the biggest source had been use of coal stoves for heating in the residences. And there was a ban on low quality coal for heating in the region, and then ultimately a complete ban on burning of any solid fuels in Krakow stoves, taking effect in 2019. And we do see, but the anticipation of that ban drove a drop here. So we saw about a 50% decrease over time in the winter average heating season and 35% drop in the annual average. So that is good news. The city had put in place these different policies. And we looked at the health benefits in Krakow using an expanded version of the benefits mapping program developed by EPA or for EPA for their assessments of benefits of cleaner air. And we expanded the health outcomes endpoints to include additional endpoints in children, again, having a causal or likely causal relationship with PM. This is fine respirable particulate matter in this case, PM 2.5. And we saw a considerable number of avoided cases of adverse health outcomes and respiratory infections, hospitalizations for asthma, and many fewer premature deaths and adult cardiovascular emergency hospitalizations. And the economic benefits gains from these avoided health outcomes were considerable. The third example is a study led by my colleague in our department at our center, Deliang Tang, Dr. Deliang Tang. And the study was took place in Tongniang, China, which is shown here on the map to the southwest of Beijing. And we had the opportunity to, quite natural experiment, I guess. Oh, I'm sorry, the slides are saving. To look at the benefits of a coal plant closure. The coal plant was located in the center of the city. This is in Chongqing municipality. The first cohort that we studied was conceived or the women were pregnant and gave birth before the coal plant shut down. And the second cohort conceived and born afterwards. And we compared these children in terms of outcomes. We looked at the environmental change as well. Now, this may not look too polluting, but it was filthy and had burned coal uncontrolled. There were no controls on that smokestack, and the coal was very, very, as I say, what we call very dirty coal. This was the first baby born into our study. And I actually was there in the delivery room. They allowed me to scrub and go in, and the mother allowed that. And that was very exciting. Here's the first baby, and here's that baby taking a gazelle test for cognitive development at age 2. Here's our cartoon for the PAHS DNA adduct. And here we also measured the levels of a protein that's very important in fetal brain development called brain-derived neurotrophic factor, BDNF for short. And here we set up rooftop monitors. We also measured and so we'd set up rooftop monitors, and we saw, comparing the ambient air levels of PAH, we saw a significant reduction between the two cohorts, 2002 and 2005. The adduct levels were also significantly lower in the second cohort, but this nice, good neurotrophin, BDNF, was significantly higher in the second cohort. And we no longer saw significant associations between the adducts as a marker of exposure and lower developmental scores at age 2 in the 2005 cohort. So benefits at the molecular and the ambient, the molecular and the clinical levels. Now I'm moving to a different level here, to a regional policy in the US, to just give you in a nutshell a case study of the Regional Greenhouse Gas Initiative and the first phase of 2009-2014. And this was a cap and invest program to reduce greenhouse gas emissions from the electric power sector. 9 northeastern states signed on, and it covered emissions from new and existing fossil fuel electric generating plants, Allowances were sold to emit a certain amount. They could be traded. The revenues from the auctions were used to support energy efficiency, renewables, and other public health benefit programs. So in this work, we leveraged a study that had been done by ABT Associates, and they actually had published this, I think, in 2017, with further work in 2019 and 20. And that study they'd estimated the drop in air pollution, in emissions, estimated the air quality change improvement, and then looked at a number of health outcomes. So I'll show you what we did in addition. We added in the child health outcomes that we were concerned about, new ones that hadn't been reckoned with in these assessments of benefits or impacts of policies on clean air. And they included autism, asthma, low birth weight, preterm birth. And we saw substantial numbers, or we estimated substantial numbers of avoided cases of these adverse health outcomes, totaling 803 cases. And here, this is new cases of childhood asthma. Already the previous publication by ABT, the previous assessment had estimated that there were almost 10,000 avoided asthma attacks in adults and children. These are exacerbations of asthma in children and adults who already have the disease. They estimated 830 fewer premature deaths, 16,000 respiratory illnesses, and quite a number of non-fatal heart attacks. So quite a few benefits from this RGGI program, considering the 9 states and the 4 neighboring states. The savings in terms of avoided costs per case for these child health outcomes were estimated at about, up to 350 million. And they added to the much larger savings in 5.7 billion in other health savings I showed you in the previous slide, a total of 6 billion in savings altogether. Now, these are underestimates because the literature provides cost per case, but they don't generally include the long-term impacts. So there has been, a look back on RGGI and how it's done. Certainly, it was a significant, and the extent to which it was successful, certainly significant driver in the observed 47% reduction in emissions from the electric power sector. But the states maintained steady growth, a lot of energy savings mounting to 12 billion, large health and benefits. But there were continuing hotspot neighborhoods where the hardest hit communities remained highly exposed, and that needs to change. And there needs to be a tightening also of the caps and of the goals to achieve the needed 45% economy-wide reduction in greenhouse gas emissions by 2030. So, and this adds to other estimates of the costs and the benefits of acting on climate change and air pollution. So we need a new paradigm which puts children front and center. And we know that we must, if we don't do that, and this was on the report in 1987 of the Brundtland Commission, that if we don't put our children's fundamental right to a healthy life-enhancing environment, we will have failed them and violated their right. And solutions are available now, and they can and must be used in ways to advance social and economic equity. And I recommend the drawdown review, and these other expert groups, IEA and IPCC. In summary, we see multiple effects. We see interactions between climate change and air pollution. We see that the disadvantaged children are hurt first and worst, and that we need to combine, have holistic policies that combine equitable environmental, social, climate policies. And back to the turning point, I think we are there, and we need to resolve and to act and get the word around about not only the seriousness of this situation, but all of the things we can do to make a difference, because there is still some time, although the window is closing. Acknowledge my many partners in the center and our community partner, West Harlem Environmental Action, and others in China and Krakow and on the NYC Study, and also particularly the children and the families who stuck with us for so long, and our funders, both public and private, to whom we're very, very grateful. So I will stop sharing and stop talking.
That was wonderful. Maybe it's me, but I was glued to the screen, so I was excited to see all the information you presented. Although some of it, is I like the benefits, the second half part of the follow-up studies.
Yes.
So definitely bringing that hopeful side to things. So I want to remind everyone that they can submit questions in the Q&A box, it's got two little bubbles on the bottom of your screen. And Beth and I will be switching on and off, but I do want to get one of my questions in is what kind of resources, does it take to do a study like this? I'm 26 years old, so some of those children that you were studying are my age, so I'm just wondering how to maintain this and continue these long longitudinal studies. And if you have any thoughts on
I would, the obvious answer is financial resources, and we were very fortunate to have continuous funding from NIEHS, National Institute of Environmental Health Sciences, and EPA over many, many years. That ended under the Trump administration. And now NIEHS is continuing to fund centers, but in a different way, not under the center program, to fund large scale or long-term cohorts like ours. And there were a number of those founded in 1998. Ours was the most consistently funded over the period up until the end of that program. But we have funding from other sources, including NIH ECHO and the NIH Infrastructure Grant Program. So first resources, you need economic resources to pay staff, to keep the lab open, to keep pay volunteers, reimburse them for their time and effort, and enormous time and effort and commitment that they've made to the study. And also you need a very, very committed staff. We have staff who've been with us almost from the beginning, and they're bilingual. Many grew up in the neighborhoods that we serve. They have master's degrees. They have a keen interest and concern about the mothers, the families, and the children in our cohort. So it takes a lot of ingredients, and so we're very grateful to those, to all of those aspects that we've been able to do this. It's been very exciting.
Thank you very much. This is an excellent talk, and I see a couple of questions coming in through the chat box that I'm going to ask you. One is that what were the primary confounders for the maternal child study that you did? And with that, someone else asked, could you talk about how covariants might have been considered, such as parental smoking, subject smoking, and other life and health choices?
I didn't quite hear the second one, but let's take the first one first.
Okay, great.
So we adjusted for potential confounders that which would be socioeconomic factors, other co-exposures that we had measured. And we've also measured, I should have pointed this out, we've also measured pesticides and lead in the New York study, pesticides, flame retardants, and bisphenol A, and a number of other chemicals. I should also have said we've been able to collaborate with many other institutions, and including the CDC. So that's those are other resources that have been incredibly invaluable, and of course our colleagues. So we have been able to adjust for a number of socioeconomic and environmental exposures. And the associations I showed you were significant after doing that. I didn't hear your second
The
question.
second one was actually the same. You actually answered it already. So
Oh, really?
they
I
were
thought I
asking
heard
about
COVID. Did I hear COVID?
no covariance. They were saying
Oh,
COVID
okay.
on-
COVID being very much on our minds.
Yes,
Mhm.
yes.
Okay.
And then another question, again, it was a thank you for your excellent presentation. Do you have any comments on research regarding children living close to airports or Air Force bases who are exposed to jet fumes? This is a big issue currently in Burlington, Vermont, Seattle, and here in Madison, Wisconsin, where the F-35 fighters are located and are actually going to be near civilian neighborhoods.
Mm. Unfortunately, we don't. We haven't studied those exposures, but I agree those are very important and need to be studied.
Okay.
First of
I
all,
have another personal question for you about
sure.
PAHs.
Yeah.
And I noticed that the state of New York has actually banned PAHs or have banned the coal tar sealants that they use. And it has PAHs in it.
Mm-hmm.
And then the second issue I have about PAHs is we use recycled tires for children's playgrounds.
Recycled
Tires.
Tires,
Tires.
like car
tires.
tires.
Right.
I don't know too much about that. About they're asking about the health effects of
Right.
from the recycling. I don't think I can really answer that in a wise way.
Okay.
Sorry.
Okay. That's okay.
I'm going to jump in here. So with this question, you know, so you got these studies done and you actually had policy that was changed. How did you know, the Columbia Center, how did everyone go about communicating that resource to the policymakers, the decision makers in charge to get them to make the change? Because I feel like for me, sometimes that's the gap is that segue from the research that you're doing and then the policymakers. So if you have any experience or examples or knowledge to share, I'd love to hear what you have.
Oh, sure, of course. So our center from the beginning has had a core, which is Community Outreach Translation Core. And that is aimed at taking data, you know, the hard data, the facts that we publish, the results we publish in peer-reviewed journals, and saying to, and translating them into a form that's accessible to not only to the participants in our studies, but also to policymakers and the broader public. And so that means coming up with accurate ways to present and explain the results in the context of real life context and even in the policy context. We're not, and a lot of that work is meant translating materials into not Chinese, but although, sorry, that's another tangent, into Spanish for our New York City cohort. But we're not advocates. And so we partnered with environmental and community groups and environmental justice groups, most predominantly or prominently West Harlem Environmental Action and others who serve on our advisory committee. And they get the word out to through their communication channels. And it's been a very effective approach. We've also testified at city council meetings and briefed government officials at different levels and described our results. And in our papers, we try to we try to lay out the context and what this might mean, what this means in terms of the real life issue. So we're trying to come out from we are coming out from the so-called ivory tower. I never did see an ivory tower, but anyway.
Thank you. We have a question from Jed Downs. When calculating the cost benefits of RGGI, or I think you called it Reggie or something like
Oh,
that.
yes.
China, Krakow were just direct healthcare costs calculated, or were they indirect benefits of preservation of intelligence and social consequences also included in the 6 billion? I'll repeat that. When calculating the cost benefits of Reggie, China and Krakow were just direct healthcare costs calculated, or were the indirect benefits of preservation of intelligence and social consequences also included in the 6 billion?
No, they were not included. Nothing. No, those things in all of the calculations that we've made, we've not been. They've been based on, for the children's health outcomes. They're just based on the cost per case, and those are usually the short-term costs. You know, like for a low birth weight baby or preterm birth, the NICU. You know, those are. If you read the literature, they're talking about immediate health care and immediately after that, you know, the short term, and not most of them not really looking over the entire life course, what those costs are. And particularly for IQ, you know, you have to think about the play out of even a small reduction in IQ, you know, on average can mean at the extreme, you have a very large effect in terms of losing. Well, I think I'm going off on a tangent there for societal benefits, but for the individual, a reduction in IQ means lower lifetime earnings, and those are rarely, if ever, you know, factored into these calculations.
Well, there's another question from Tom Hollenhurst. It says, have you considered the benefits of green space and the access to green space and recreation for children in these areas?
What a wonderful question. I mean, all these questions are so good. That is so important. Green space for climate change, to protect children from heat where they live and play and go to school. That's critical. And green space for mental health as well is so important. I don't know of studies that have, and I did look a while back, that have tried to assess the benefits and even monetize them through prediction modeling I'm talking about. Because but that's something that should be done. And I think, could be done. There may be some studies ongoing in India where they're thinking hard about putting shade into these communities that are so hard hit.
Dr. Perera, another question is just, you know, where do you go from here for you? You know, what are you studying next, I guess, is what the...
Well, I just finished a book on climate change in children, and will be coming out. Oxford University Press is publishing that later this year. So that was a project, but I'm also very interested in transportation related projects, and like there's ongoing work through a collaborative group I'm part of, which is looking at the standards for medium and heavy duty trucks and buses, electrifying those vehicles, and what the health benefits would be in key cities. And I think that case studies can be very important. Like Reggie, we did another one for Transportation Climate Initiative, which at the moment is not going forward, but that I think can bring out of the realm of abstraction reality and some real power for bringing people into this very, well, everybody uses that term, existential battle, but to bringing people into the effort to make a difference, because there are things that all of us can do, and I should have said that through our individual acts, but also joining coalitions and advocating for broad social and policy change. But you know, to see the to see the predicted benefits will be very helpful in engaging people who have stayed on the sidelines, either because they think, well, it's hopeless, there's nothing that can be done, or have just decided they would, you know, blank it out, and hook them in to become members of this large worldwide coalition to help our children and help everyone.
Thank you, Dr. Perera. Beth, do you have any other questions? Okay, seeing as we're already at 7:59, so it's like a good timing point. I want to thank you, Dr. Perera, so much for your presentation tonight, and bringing to light the realities of science, study, environmental health, climate change, air pollution, and our children's health. So thank you so much for your past work. And it sounds like maybe some exciting things for us to keep our eyes out to come in your book. So might have to get a copy for our office. Maybe we'll just do a little book club on it. So got ideas already circulating through my head. And as I'm thanking you, I did just get a question. What was the name of the book?
Well, the name of the book, and it'll be a little while in coming out, because the chain has been, you know, there's been a slowdown in the production due to all these, well, you know. But the title is Climate Change and the Peril, no, Children's Health and the Peril of Climate Change. Got that one backwards. So I will send you that information.
Great, thank you. Do you have any last words for us tonight?
No, just thank you. And I think it's wonderful what you do, putting on these webinars. And it's been a pleasure being part of it and hearing from people who have attended and had questions and ideas and suggestions, and pleasure. So thank you. Take care.
Yeah, thank you. And I will just make a note for attendees that we have one presentation left in our series of 4 speakers. Mary H. Ward will be speaking about nitrates and water quality on March 16th at 7 p.m. Again, Mary Ward will be speaking about nitrates and water quality, and it will be the same link that you used tonight. So that'll be the final presentation in our series, and I hope you can join us, or you can join WEHN on any of our many topics we cover and visit our website. And thank you all. And thank you, Dr. Perera, for your time.
Pleasure. Good night.